Hi, my name is Jim Davis, and I'm the fire chief here in the city of Fort Worth. And today I'm joined by Fort Worth Police Department Chief Neil Noakes and Office of the Medical Director Dr. Jeff Jarvis. I appreciate both of you joining us today on this video. What we're here to discuss today is the recent national attention that's been placed on patient restraint related to different police and fire and EMS issues across the country. Most recently, where most of us are familiar with the events that occurred in Memphis. There's also been restraint issues that have occurred with EMS providers in Illinois. And unfortunately, both of these have risen to criminal level and indictments against providers in the fire, EMS, and police professions. We all got together with the idea that we are one bad call away from that happening here. And we want to put everything in place to try to do two things. And I think you're going to agree with me on this. One is we want to bring attention and awareness to it. And two, and most importantly, we want to encourage each other in our departments and our organizations to make sure that they work collaboratively to try to prevent this from happening in our community, with the understanding that we're working together to try to give the best equipment, the best policies, and the best training to prevent it. Would you agree, Chief?
Absolutely, no question about it. And thanks, first of all, thank you, Chief Davis, for asking us to be here. Doctor, it's always great to be with you. This is a critical piece for us in the police department. And I know it is for your departments as well. What I love about this idea is it gets us all on the same page, talking about the same things in the same vernacular, if you will. Usually we're all showing up on the same scenes. One may show up before the other sometimes and the opposite another time, but eventually we're all going to be there working together. And we like to practice like we play. If we're going to be working together, we don't want to wait and figure out how to do it when we're in the middle of an emergency. We want to make sure we know how to do it prior to, so when we get there, it's automatic.
So Doc, recognizing that the Office of the Medical Director and you as our medical director, responsible for the city of Fort Worth Fire Department, Fort Worth Police Department, MedStar, as well as 14 organizations that we all work with collaboratively in the North Texas area. It's important to have you here because it's not just the restraint and the detainment of a suspect or somebody preventing themselves from hurting themselves or others, right, but it's the patient care aspect that goes into it. Can you talk a little bit about that?
Yeah, absolutely. So when you have agitated people, sometimes they're patients, sometimes they're not. The key distinction here is whether they're confused or their mental status is altered. So if they're making sense and they're just very unhappy, that's not a medical issue. However, if they are violent and agitated and they're confused, they're not making sense, they don't know where they are, their words are just going from one place to the other, that is a medical emergency. These are people who are announcing that they are likely to deteriorate. These are the people that are most at risk for dying. And the basic physiology involved with this is that you are so ramped up, typically from substances, cocaine, methamphetamine, other drugs, that your metabolism is just cranking up and up and up. And when we do that, it's essentially like you're running a sprint and you're completely anaerobic. So you're just not stopping and you're building a bunch of waste products. The way that you have to get rid of those waste products is by breathing rapidly. And this is where we get into trouble. The problem is these people are dangerous to themselves, to others, and we have to limit their ability to hurt other people and hurt themselves. So some restraint is likely to be needed. But when we restrain their ability to breathe, we restrain their ability to blow off those toxins. It may look like they're breathing fine, but they're not breathing well enough to be able to get rid of those toxins. So breathing is not the same thing as breathing adequately. You have to be able to breathe faster to be able to prevent yourself from decompensating. And that's really where we get into trouble with the restraining these patients. Restraints that may be fine for the average person who isn't ramped up like this, but become really dangerous with these types of patients with agitated delirium.
So Doc, let me follow up with you on that, because with the national attention that's placed on it, there's a lot of body camera video.
Yeah.
And a lot of the conversation is around mental health
Mhm.
and a lot around things such as excited delirium.
Sure.
And excited delirium is a big bucket term that a lot
Yeah.
of different things, I think you'll agree with that.
Sure.
But for the non-healthcare provider,
Mhm.
on a routine basis,
Yeah.
primarily our police officers, can you also explain that not every one of these things where people are agitated,
Mhm.
where they are in appearance of, causing their own distress and problems for police and fire and EMS,
Yeah.
but the importance of oxygen to your brain and
Mhm.
glucose. Can you
Yeah.
talk about how that can mimic a lot of these behavioral health issues?
Yeah. So one of the things that we all have to do is when we see someone who is agitated like this, we have to ask ourselves why. So there are some conditions that have nothing to do with substance abuse, mental health. For example, a diabetic who has taken insulin but didn't eat, their blood glucose gets very, very low. They look drunk. Sometimes they can become agitated. The solution there isn't sedation, it's glucose. We need to feed them. The other thing that can happen is seizures can mimic some of this. When you have a seizure, as you're waking up, you get very, very confused. And if you have people in your face, you can get very agitated. For those people, the solution is pretty much leave them alone, get out of their face. So the reason for the agitation is important. The challenge is sometimes we don't know what the issue is, and we won't know until we can get a blood sugar, we can do some monitoring. So we have to have a cohesive approach to dealing with these patients who are agitated and confused.
So in the meantime, you got to be able to get that assessment.
Absolutely.
And in a lot of cases, you have to go hands-on with people in order to accomplish that. So Chief, can you explain to the non-officer what the training looks like for the Fort Worth Police Department and what the expectation of the Fort Worth Police Department is regarding restraint and position related of the position of the detained regarding their position and your expectation of how they're restrained during the course of their detainment?
Absolutely. Great question, Chief. So first of all, with us, one of the things that we're going to do, because again, every situation where all three of us are likely to respond, sometimes the roles will shift as far as who should take lead and take control in that situation. If we respond to a scene where there's someone who's an active danger to themselves, the public, someone who poses a threat, PD needs to step in and take control of the situation. We're trained to use only the amount of force necessary to achieve a lawful law enforcement objective. And once that threat is over, once it's neutralized, the person is secured and in custody, force stops. But even at that point, our job's not over. Because even if someone's in handcuffs, it doesn't mean the threat is necessarily over, not only to someone else, but to themselves. And given someone who might be experiencing an extreme medical condition, we have to make sure that the position of the person is such that it allows that proper breathing that you're talking about. It would be easy just to leave someone face down on the ground, or if they're struggling to have someone face down on the ground with an officer on top of them. Sometimes we have to do that to keep them restrained. We have to make sure we're not restricting the breathing. One thing I've heard said over and over in the law enforcement community in a situation like that, if the person is yelling at the officer while they're still struggling, the officer might say, "Well, you're talking, you're breathing." That's true to a point, but as you said, are they adequately breathing?
Right.
Are they breathing enough that they can sustain life? So what officers are taught to do is put someone, once they're restrained, in a recovery position, preferably where they're sitting upright, not hunched over, nothing that's restricting the diaphragm, the lungs, or their ability to breathe, but sitting up in a position where they're able to breathe just fine. And what we want to do is make sure we understand at that point, yes, we still are responsible for keeping that person under control, but you've got a job to do too. And we have to make sure that we're not doing anything that interferes with your preservation of life duties that you have at that point. Because regardless of what the person may have done, regardless of the fact that they may be a criminal, we want to make sure they go away okay. Go to the hospital, go to the jail, both. We want to make sure we allow you to do your job and you feel comfortable stepping in to do that job, that we may still be having to restrain in some way that person to make sure everyone walks away from that okay.
So Doc, let me go back to you and ask you this, and that is in reference to what the Chief just said.
Mm-hmm.
You having worked in emergency medicine for a lot of years and being a paramedic before that, I think that you're going to agree with me that in a lot of situations, patients, they feel an aura. They know something's happening to them, be it a seizure.
Sure.
And in a lot of cases, when they say, I'm going to die. And talk about that for just a second.
So slightly out of this particular concept, but when a patient tells you, I feel like I'm going to die, you should get very, very nervous, because most of the time I hear I'm going to die, something bad happens after that.
And the reason I ask
you got
you
to trust your patients.
And the reason I ask you that, and I didn't mean to put you on the spot without telling you exactly why I'm asking you that, is the I can't breathe conversation.
Yeah, absolutely.
And I know that that's got a stigma attached to it now nationally, and that's not the purpose of this conversation.
Yeah.
However, I think it's important that all of our folks hear that there are auras that patients experience in which I can't breathe is one of them, and should be taken seriously. And would you agree?
Absolutely, I would agree. And I'd like to explain it.
Oh yeah, please.
So think about this. For a brief period of time, I was actually in shape and would swim. And when I was trying to teach myself how to swim, what I would find is I felt like I just could not breathe. I couldn't get enough air in. If I were to measure my oxygen saturation, it would have been 100%. The problem wasn't I wasn't getting enough air in. It was that I was not getting rid of all the carbon dioxide, the waste products. So I was generating so much CO2 because I didn't know how to swim very well. I wasn't able to blow it off. And I felt like I was dying and couldn't breathe. The people who you see in these videos, if they truly are having a medical emergency, when they say they can't breathe, it's because they truly feel like they can't breathe. Even though they're able to push air past their vocal cords and make noise, it's not enough. And the reason it's not enough is because they've built up all these waste products, all of this CO2. The way you blow that off is by breathing faster and deeper. And even though they're able to talk and communicate, they're breathing, but they're not breathing adequately to get rid of those waste products.
So, Chief, this is the point of our conversation that started this whole first meeting that we had, and that is Doc's talking about these folks have jacked up metabolisms, their heart rates are up, their breathing is deeper. And that's the same thing going on with your officers or our firefighters and emergency medical technicians at the fire department or MedStar. Mm-hmm. So part of this, the purpose that we put this video together is for education and for awareness, but part of it was we wanted to collectively make a call to action and a commitment to the folks that are going to watch this video that we need things from them and we need them to look after each other. Can you talk a little bit about that?
Absolutely. I tell you, I think this is probably the same for you. One of my primary goals every day I wake up is to make sure my officers go home safe every day.
Absolutely.
We also want to make sure everyone else goes home safely, and so does every officer out there. No officer comes to work wanting to be in an interaction where someone loses their life, regardless of who it is. It's our job, I believe, to make sure that officers receive the training, the support, the encouragement, the equipment they need to get the job done. And then that is our call to action. Use it properly, rely on your training, work with our brothers and sisters in the emergency response, first responder community to make sure we're all able to do our jobs, we're able to do it well, and we're on the same page. We have different responsibilities, different duties when we come to a scene like that, but everyone is just as critical as the next. And by doing this together, having these conversations, not just us, but our officers, our firefighters, our paramedics, having the same kind of conversations, the same training, I believe we're doing what we need to do to make sure they have the skill set they need and the encouragement, support they need to get the job done right. And when we do the job right, it's better off for everybody. So this is a great conversation. I appreciate the fact that you're bringing this all together today.
So Doc, can you explain to everybody that's going to watch this the equipment that we all carry from an EMS response standpoint in order to help prevent a tragedy from occurring like occurred in Memphis?
Absolutely. So when we need to be able to get a better idea of what's going on medically with these patients, rule out the other causes, for example, low blood sugar. But the other thing is we need to get an estimate of how well they're breathing. And there are two things that allow us to do that. There is pulse oximetry, goes on the finger, the ear, or somewhere, to give us an idea of how much oxygen is in the bloodstream. But that indicator, which we might think is all we need, is actually what we call a lagging indicator. In other words, the value that it is giving you is old information, it's old data. What we need to look at, which is much more real-time data, is the end-tidal CO2, capnography. This is something that goes around the nose and measures the amount of these waste products that we're bringing out. It is a much better indicator of respiratory effort. So an analogy a friend of mine uses is trying to determine a patient's respiratory effort by looking at the pulse ox is like driving 100 miles an hour in reverse, looking through the rearview mirror. The information you're getting is old. If you want to drive 100 miles an hour, which I would suspect you would think is a bad idea, you probably want to be looking through the front windshield going forward. That is real-time information. That's the reason you need the end-tidal CO2. The one thing that we have to understand is it may not be possible to get that equipment on early on when there is still a threat. Once that threat is minimized, I like what you said about lethal force. You have to use the minimum force necessary. We also have to do the same thing, the minimal restraint necessary, the minimum interventions necessary to take care of these patients. But absolutely, as soon as humanly possible, we have to get that monitoring equipment on to be able to not only see where their breathing effort is now, but make sure that it doesn't change.
So simplistically, the pulse ox is measuring
Pulse ox.
oxygenation.
Yep.
Capnography is measuring ventilation.
Yep.
And ventilation is more real time than
Absolutely.
than pulse oximetry.
Yep.
And then with pulse oximetry, this is not like high school, right? A 90 is not an A, right?
Correct.
It takes longer to go from 100 to
Yep.
90% than it takes
Absolutely.
to go 90 to 0.
Absolutely.
So it's like falling off a cliff at that point.
Absolutely.
So just because they have a good pulse oximetry of 90 in theory,
Yep.
that's equates to an arterial blood gas PO2 of 60, and
Right.
that's bad, right?
Yeah.
The additional thing that point out is that we shouldn't forget that when you get them on capnography, you also have the ability to provide oxygenation through that same capnograph.
Yeah, there are a couple of things with oxygen for these patients. Number one, they may still be agitated and we may not be able to get the end-tidal CO2 on. We may not be able to keep the oxygen saturation probe on. We have to assume they're hypoxic, or we have to assume their oxygen level is low, because it turns out low oxygen level can make you behave like this. So just assume it's low, put a mask on and turn it all the way on. Spinal Tap would say turn it to 11. The reason for that, it does two things. It gives them all the oxygen they need, but it also protects us. If these patients are spitting, there's a face shield on that is not preventing them from breathing, and it's actually helping them breathe.
And it's not unheard of to do what you're doing, not just from the spitting component.
Yeah.
But in pediatric medicine,
Sure.
it's called blow by oxygen,
Yeah.
right? They give the kid the mask and the kid's just playing with it.
Shove it in
and
the
they're
teddy
getting-
bear.
and
as a matter
they're-
of fact.
Exactly.
Yeah.
So it's not, in,
Yeah.
in principle, a lot of people will think, well, that doesn't work. But it's been proven through the
Oh,
pediatric
absolutely.
world that it does. Correct?
Yeah, and in the adult world, it absolutely turns out more oxygen raises your oxygen level.
So before we come to a close and for last thoughts and comments, Chief, I'd like to, we had a good conversation about body cameras and everything that body cameras offer for transparency. It also offers a great opportunity that 99% of the body cameras that you're telling me that you look at, officers are doing everything right. And this is a great opportunity to explain to firefighters, EMTs, paramedics at MedStar, everybody involved, that the body camera can be your best friend instead of always thinking that it's your worst enemy. Can you talk about how they're supposed to always be on a situation like this, and that just it shows a narrow window, but it's recording conversations, and how this is an opportunity to verbalize your assessment, to make sure that you're talking and communicating to each other. So when and if this ever happens and there's scrutiny brought, that there's good opportunity to demonstrate that there's cooperation, that there's collaboration, and that there's good communication, and that we did everything possible to prevent a good outcome in a situation that unfortunately may have gone bad. Can you talk about that?
Absolutely love to. Absolutely love body cameras. When we really began a really robust push for body cameras, I was actually working in internal affairs, and there are a lot of people that thought, well, our job's going to get a lot harder because we're going to see a lot more. Those were the negative naysayers. And the rest of us thought, this could actually be a really positive thing, and it was. 99+% of the time, it exonerated officers. It showed, like you said, the amazing work they were doing every single day. One of the things we tell officers when it comes to the audio portion of the recording, when you can, obviously in a really high stress situation, you're just trying to do what you need to do to take care of the job, narrate what you're doing. We know what we're doing up here as we do it, but when someone watches it, hearing you talk about what you're doing as you're doing it, not only can it help you process your thoughts as you're working, it explains everything. You're narrating what you're doing and why you're doing it. So don't think you have to be quiet on body cam. Do your job as you would normally do it. To all the firefighters and paramedics, when you show up on a scene with us, just assume that camera's on, because it's really good chance that any time that you are coming with us, if you had to respond as well, it's going to be one where that officer is required to turn the body camera on. See it as an asset. Use it as a tool. Use it as something to show what you're doing, why you're doing it, how you're providing stellar service to the community day in and day out. And do not look at it as a negative. When we're out there doing our job, when we're doing it right, we love to put that on display, and body cameras can do that.
And there's also an opportunity when you're verbalizing it to reset the frame of the conversation, because it clicks with somebody else that, oh yeah, we got to get him off his stomach or something
Absolutely.
like that. So I think that there's so much attention placed on the cameras, and especially in your world, but not so much in our world.
Yeah.
And I think that we really need to emphasize the importance of the positivity that it can bring to a situation like this, and that folks should use it as an opportunity to document what they're trying to do to provide a good outcome.
Absolutely. And if I may, Chief, you said something that brought a thought to mind. If we're on a call with a paramedic or a firefighter and we see something that looks dangerous, we're going to say something to you, or we're going to step in and help out. If we ask that if a paramedic or a firefighter sees something that may be dangerous that we may not realize, especially if we just had a knockdown, drag out fight with somebody to get them in handcuffs because they needed to go to jail and didn't want to, maybe we don't realize the position's off. Maybe we don't realize they're having trouble breathing. And I think sometimes we have a bit of hesitation crossing our disciplines trying to tell someone what they need to do. But that's in your wheelhouse and maybe not always in ours. We ask the paramedics and firefighters to step up and say, hey, you know what? We probably ought to set him up. Looks like he's having trouble breathing. Or, hey, do you mind if I do some testing here? We've got some great tools we could use to make sure everybody's okay. Please step in and say those kind of things, because sometimes, especially in the heat of the moment, we could use those reminders as well.
So, Doc, why don't we just give him that drug? Give him that drug. Give him that.
That's right.
That ketamine thing. Give it to him.
Absolutely.
Can you talk about how that it's got its place?
Yeah.
But that is not the first thing pulled out of the bag.
So absolutely. So the drug is ketamine. The drug, unfortunately, has been involved in some incidents, the Elijah McClain case in Colorado as an example. Overall, it is a pretty safe drug. As a matter of fact, for these patients, it is probably the most effective drug and the safest drug for that patient.
Because it provides sedation and allows them to continue breathing.
Absolutely.
If they're taken care of properly in positioning. Correct?
Yeah, absolutely. It is. So what we need for these folks, we talked about this ramped up metabolism. We need to turn that metabolism off. We need to ramp that down as quickly as we can. So a drug that does a great job of that, but takes 30 minutes, it's not very helpful. A drug that can turn this off very quickly in 5 minutes, way more helpful. That's ketamine. Ketamine is very effective because it doesn't inhibit your ability to breathe, except in those rare times where it does. So no drug is perfect. You have to weigh the benefits and the risks. The risk of the drug is that it can, in a small number of cases, inhibit your ability to breathe. So what do we do about that? Well, we monitor. And the key thing, what I liked about what you said, there are two things there, is number one, it's not the first thing out of the bag. The monitoring equipment has to be the first thing out of the bag. Ketamine, if you give ketamine to a patient who is agitated because their blood glucose is 2, not good for them. It's kind of embarrassing. It's bad for the patient. So we have to assess first, then go to medications if there is no other way. We go through all the verbal de-escalation. I would assume if we've already gotten to this point that the officers have already done that. The next thing is we absolutely have to monitor for those rare events where they do have breathing problems. That's where your pulse oximetry, your end-tidal CO2, and just your normal vital signs, EKG, get those things on as early as possible. But it is a wonderful drug when used appropriately and when we understand it's not perfect. The other thing that I wanted to say, the scenario that you led in with, I think is one of the challenges. The impression in the general public is that officers are telling EMTs and paramedics and firefighters to give ketamine to sedate the patient so they can take them to jail. And I think it's very important for all of us to say that does not happen. That is not what's going on here. There's actually a huge research project that confirms this. This isn't just our opinion. When ketamine is given to someone, they go to the emergency department. It is not done to facilitate an arrest. But the perception, I think, is important. So if what is heard on video is an officer or a firefighter, first words out of their mouth are, you need to give them ketamine, the impression is bad. And it is something that we now have to explain, even if that's not what the officer meant at all. And even if absolutely they needed ketamine, it's a really bad perception and it's difficult to explain. So let's make sure that doesn't happen.
Right. Because the goal there is to make sure that you're using the drug, not just correctly, but in the right situation.
Absolutely.
As a supplement to the other care that you're providing
Correct.
to prevent the patient
From harming themselves.
or others.
Yeah,
Right.
absolutely.
So, man, our time has flown by here. So I'm going to turn it back to you for your last thoughts and comments to our general population of both police, fire, EMS, both city of Fort Worth, the entire system. Last things you'd like to say before we close?
Last thing I want to say is thank you. Thank you to all the men and women that go out there and serve every day and do it so well. What we're talking about is just a way for us to make sure we're coming together. It's not that we're doing things wrong as it is, but no matter how well we do something, we should never settle. We should always try to do better. We should always look at partnering even more, because the more we partner together on these calls where we are working together, the better off we're all going to be.
Dr. Jarvis?
Again, thank you very much. This is an amazing opportunity. It really highlights the fact that with these critical incidents, we have to work together as a team. And I think the other thing all three of us would agree is we got into this job to help people. We do it in different ways, but we did it to help people. This, if we can appropriately take care of patients, it's going to help us help them, but also help each other. We have to be able to go home at the end of the shift safe and making sure that we haven't put our livelihoods at risk, but most importantly, making sure we're doing everything we can do to help our patients. Teamwork is the best way to do that.
And I'll close by saying that, first of all, I appreciate the collaboration on this project. The idea is not to beat up fire, police, EMS in Memphis or in any other city. However, the worst thing that I think we can do as leaders here is not try to learn, not try to promote a sense of cooperation, collaboration between our agencies, and assure the folks that we're asking to watch this video that we need that from them in order for us to help defend and promote the good work that they do every day.
Absolutely.
So I appreciate both of you joining me for the short video. I hope that you guys got as much out of it as I did, the conversation, and I hope the viewing audience does as well. So thank you very much for what you do every day for the city of Fort Worth and for the North Texas region. Stay safe.